Good morning and welcome to today's webinar entitled Increasing the Use of Monoclonal Antibodies in Virginia. My name is Abraham Segrist and I'm the Vice President for Quality and Patient Safety here at the Virginia Hospital and Healthcare Association. In support of the Virginia Department of Health's efforts to increase utilization of monoclonal antibodies for the early treatment of COVID-19, the VHHA is pleased to host a statewide discussion to share insights and experiences from Virginia-based providers who have incorporated these therapeutic agents into their clinical service offerings. Our colleagues from the Virginia Department of Health, Sentara Healthcare, and Inova will present this afternoon and will be available to answer questions at the end of the webinar. Before we begin our formal presentation, I would like to review a few housekeeping notes. This afternoon's webinar is being recorded. All participants are in a listen-only mode. To ask questions or make comments, you may do so by typing in the questions box in the webinar control panel. The slides from this afternoon's webinar are also available for download in the handout section of the webinar control panel. And finally, a brief feedback survey will launch at the conclusion of the webinar. The agenda for this afternoon's program is as follows. First, we will hear from our colleague, Dr. Chris Guy-Megame at the Virginia Department of Health. After Dr. Guy-Megame, we will then hear from representatives from two Virginia Health Systems. First, Dr. Joel Bunby with the Sentara Healthcare System, and then Aaron Hudson and Dr. John Paul Fedoresi from Inova Health System. We will then have time for questions and answers at the conclusion of the webinar. Before I move to our first presenter, I will briefly review our objectives for this afternoon's presentation. Our goal is to provide each of you with a status report on the current use of monoclonal antibodies across the Commonwealth and a national update. We will then share experiences and insights from providers currently using monoclonal antibodies in Virginia and hopefully provide guidance on how you can increase your use of monoclonal antibodies in your clinical setting. So without further ado, it is now my pleasure to introduce my friend and colleague, Dr. Chris Guy-Megame with the Virginia Department of Health and also a practicing emergency medicine physician at the University of Virginia. Chris?
Thank you, Abraham. I just want to note that in working with VDH over the last several months on the COVID response, that VHHA has been an essential partner in all of the ways that we've been able to try and meet the needs of the patients and the health systems in Virginia. If we could have the next slide. So this is the major issue that many of us have been dealing with for the last couple of months. We all know that the COVID pandemic has been a severe event throughout the Commonwealth and throughout the country with large numbers of cases of people with infections, hospitalizations, and mortality. But over the last couple of months, we have seen extreme utilization of hospital-based resources. This is part of the daily report that VHHA puts out, which shows the inpatient bed utilization in Virginia. You can see we had our two earlier peaks in the spring, then the summer, and of course what we're going through right now. So we've learned how to take care of patients better. We've learned how to help them survive this illness. But what we still struggle with is the use of the hospital. Now, fortunately, we do have an option or a set of options to help reduce the need for hospitalization when patients have COVID-19. We have the next slide, please. And what I'm talking about is the use of targeted monoclonal antibodies that have been developed to directly target the SARS-CoV-2 virus in circulation. So we call these MABs for short because the names are just too difficult for me to pronounce over and over again. The idea here has been that if we could administer these monoclonal antibodies to patients who are early in their disease before the huge inflammatory cascade occurs in some patients, that we may be able to alter the course of the illness. We may be able to potentially keep them from being as contagious by reducing their viral loads. And ultimately, we may be able to improve the amount of resources that we need to use for each individual patient in terms of hospitalization. These antibodies have been evaluated now in mild to moderate COVID illness, not so much in severe. And we're not talking about patients with severe illness, just to be clear. These antibodies are very similar to monoclonal antibody products that have been used in other illnesses. But what is significant about these is rather than targeting parts of our own body's immune systems, like some of the things that we're seeing in oncology and rheumatology, these agents are targeting the virus itself. So they're actually very benign. There is a small incidence of allergic and infusion reaction, as you would see with most infusible drugs, but we're not seeing huge systemic effects as a result of these administrations. The products that we're going to talk about, first of all, none of the people on the panel today have any conflict of interest. The federal government has purchased these products, and we are not invested in any way with these companies. But they've been made easy to use. Single dose administration, just one time. You don't need to bring patients back for serial doses. And typically they run over about an hour, but I'm sure we will talk about that because we've heard some new developments as well. So there's early evidence, just like everything with COVID, on the effectiveness of these treatments. Can we have the next slide, please? So because there is early evidence, the FDA has taken the step of granting an emergency use authorization. This is different than FDA approval, so these are still not considered approved standard drugs. But with the EUA, within narrow indications, it is recommended by the FDA to consider the use of these agents with some shared decision-making with patients. So the criteria that we are looking for in terms of the patient population that could be targeted include patients who are test positive for the SARS-CoV-2 virus. So we're not talking about a clinical diagnosis here. We really want to have a test that is positive. And the earlier, the better. So what is recommended is the administration of the drug within 10 days of the onset of symptoms. Further, we're looking at high-risk patients, and I'll cover that on another slide. But not just every patient. If you have a 25-year-old healthy person who's got early COVID, this is not the drug for them. This is not what we're talking about. But what we're talking about is giving patients who are at high risk for complications, hospitalization, and even mortality, this drug early in their course. Can we have the next slide, please? So there are two groups of agents that have been approved in the initial EUA. One of those is called bamlanivimab, or BAM, and the second was what has been referred to as the Regeneron cocktail, which is a combination of two agents. And these have been the agents that we have been using now for a couple of months. But on February 9th, so just really breaking news, so 2 days ago, the FDA did grant another EUA for a combination of bamlanivimab and etesevimab to be administered together in the same group of patients. So we now have really 3 treatment options that will become available, and 2 that are currently available to patients in Virginia. Can you have the next slide, please? So here's that high risk criteria that I've been talking about. Really, when I have been talking to groups and when we've been working with health systems and other providers, we've really been talking about adults. There is an indication in the EUA for adolescents, and you can see the high risk criteria there. But what we've really been focusing on is this group on the left. So adult patients who meet any of these criteria. So the 2 that really stand out to me whenever I'm talking about this are age greater than 65 and the obesity. We know that both of these are very common in our sicker COVID patients, and we've seen that there are highest complication rates in the elderly and the obese. So what I like to think about is, as Abraham said, I am a practicing physician, and when I see a patient in the emergency department who is elderly, maybe a little frail, and ordinarily with COVID, if we had diagnosed them, we would just say, well, you know, you don't have an oxygen requirement today. We'll give you some Tylenol, maybe some fluids, and we hope you feel better, and you go home, and we'll maybe set up some home monitoring for you. So sort of a phone number and a prayer. And I think that's made many of us uncomfortable with that as our only option in this group. So with this EUA and this set of medications, we now have a medication that we can have the option of using that may be effective in reducing some complications. If we could have the next slide, please. So here's really what I'm talking about. All right, this is an exemplar of one of the studies. This was the BLAZE-1 study, which was really a phase 2 study of the bamlanivimab. There have been subsequent smaller studies, and there are many studies in process, but basically this is a dose ranging part of the study against placebo. And you can see that what we're measuring here is hospitalization incidence. Now, there are lots of criticisms of the study, and I'm sure our panelists will be able to talk about that, and we can field those questions. But the bottom line is that the absolute risk reduction for hospitalization and or ED visits was significant. Relative risk reduction about 70%, and absolute risk reductions you can see about 4 or 5% in that group of patients. So what we see, can we go to the next slide, please, is when we start thinking about this in two different ways, we may be leaning towards using these drugs. So the one way we always think about things as clinicians is, how is this going to affect the individual patient right in front of me? And so the evidence does show, well, it seems to reduce viral load, it may reduce the admission rate, may reduce ED return rate. Clearly, we are not claiming any mortality reduction on this. But when you think about giving this type of drug to thousands of patients across a population, focusing on high risk, I think we really have systemic effects that will help our patients, our communities, and our healthcare system to get through the waves like we're experiencing now. And so we can see that if this really works, we're going to also have a reduced inpatient burden, potentially reduce inpatient crowding, and in theory, fewer cases translate to fewer deaths. And the next slide, please. So our program goals at VHHA have been really to take this ball and run with it. We really want to try and maximize the appropriate utilization of the drugs that have been allocated to us by the federal government with the appropriate medical indications over these current 3 months. Now, this slide is maybe a month old, so I think, you know, we're still really targeting the next month or two to really try and get through this surge. We also have an eye towards equity in terms of getting these agents to underserved populations throughout all the geographies in the Commonwealth. So I think that may be my last slide. Oh, no, there's one more slide here that we want to hit. So just quickly, you know, I've had a chance to talk to many different physicians, and there are some folks who are very skeptical of something that's under an EUA. And just to clarify the program, we have access to these drugs through Operation Warp Speed, which is the federal government's Health and Human Services program to get novel therapies out to the states and to patients. So Jordan Asher, who is the chief physician executive at Sentara, sort of gave us this idea on one of the calls. He said, you know, really the concern has been the number needed to treat. And the number needed to treat is how many people do you need to give a drug to before you see the desired endpoint effect. And you can see with the bamlanivimab alone in the BLAZE-1, depending on the risk profile of the patients, if you use it from the high risk to very high risk, the number needed to treat is somewhere between 10 and 25 patients. Well, that may sound like a lot. You may say, boy, I got to give this antibody stuff to 10 or 15 or 20 patients before we're really seeing the effect. But what Jordan pointed out to me and others was, we do a lot of other things that have a number needed to treat that are a lot higher than this. And we don't just do it one time in one infusion. We give these people medicines multiple times a day for their whole life. And so you can see the numbers for yourselves, but things like anticoagulating for AFib, using statins to prevent heart attacks or strokes, and using antihypertensives, which I think every clinical person here who's attending has done in their career in one way or another, have much, much higher numbers needed to treat. So I think if we can work through the logistics of doing something like this, and it's a single dose, and it gives some of our high-risk patients a fighting chance, it's a conversation we'd like you to consider having. We have the next slide here. The last thing I'll cover is the cost issue. We all have a perception that monoclonal antibodies are expensive products. We see this in the oncology and rheumatology world, and that is true. But in this particular case, the federal government has pre-purchased hundreds of thousands of doses. And what we've seen is rather than this being a scarce resource, it has been in surplus. And part of that is because of the logistical concerns and the uncertainty about the use. But patients are not charged for this drug. And that's one of the things that we'd like to emphasize with anyone who's very concerned about passing along the cost to patients. So I think those are my last slides. And I think Dr. Bundy is going to go next. And we'll have plenty of time for questions.
Thank you, Chris. I appreciate that presentation. And I, obviously working for Sentara, I listen to Dr. Asher quite a bit, and we talk about the number needed to treat. So I appreciate that. Next slide. So I'm not expecting you to be able to read this, but we talk a lot about the problems with giving these monoclonal antibodies. So for Sentara Healthcare with 12 different hospitals, where do we do this? And so this slide is really just a representation of, we had to set up places for people to go throughout the organization, because you couldn't expect someone up in Williamsburg to drive down to Virginia Beach or to Northern Virginia. So the first thing we did at the very beginnings, we sort of said, well, where can we do this? Well, it wasn't simply a matter of finding a location. We had to find a location with people that had the skill set to do the infusion, near a pharmacy, near a provider, and because these were COVID positive patients, what about the ingress and egress for those patients in and out of the building? So it had to be safe for the other patients that were there, and had a time that we could sort of work through, because many of our infusion centers were busy giving infusions to other patients already. So trying to find a place, and in the beginning, and we still do this, is the majority of the work is clinic-based. So we have infusion clinics. Some of them are in treatment rooms, maybe adjacent to the emergency department, but that's mainly what we've done. On the south side in Hampton Roads, because we have a number of hospitals here, we were able to do it in one infusion center. So if you're in Norfolk or Virginia Beach, there was one location to come to. But for the most part, we set up a clinic at every single facility across Virginia. Next slide. And again, not to look at this in detail, and this isn't complex, but it's sort of complicated, from the time the patient gets sick to the time the patient actually gets treatment. There were a lot of steps that people had to work through. And again, I've got a slide that shows this a little bit easier, but when we first mapped this out, we're like, oh my gosh, how are we going to do all this and get it done within 10 days, which was a problem. Next slide. So for most of our patients, and I won't read through the slide, but it truly was a matter of, okay, I'm sick. I finally get to my PCP. I get a test, whether it's a PCR or an antigen test. My provider, my physician calls me back. We talk about the monoclonal antibody. And we started, and I'll just say, we started with a paper process where we're moving to Epic, because we realized that we have a lot of people in Virginia who are not medical staff in Sentara, so they couldn't easily just write an order in Epic. So how do we make sure we capture those? So we did develop a paper process where we fax that. We then review those. We review them Monday through Friday. We don't, over the holidays, that was a hiccup as well, because there wasn't someone to review it every single day. And then we actually sent that to the infusion center, and the infusion center would call the patient back. And it was this sort of process, which you can see there were quite a number of steps, and it wasn't the most efficient, which then led to The next slide. What we have found is that over 60% of the doses we've given are in the last 3 days of eligibility. Well, that's cutting it close. And there are people who are on day 11 or day 12. But you know, there's a lot of people. So by the time we work through that process, which has lots of steps, people were either right at the very end, we had to rush to get them in. So we were thinking, well, how could we do this more efficiently? How could we lean out all of the inefficiencies? Next slide. So we thought about, could we do this in a process that was different than the one we had started with? It was difficult, the infusion centers, we had worked through the logistics of that. But was there a different way to do it? And, you know, when we think about a lot of the patients we have, either dialysis patients or the homebound, have horrible access, you know, are there, and skilled facility patients, how could we get those patients monoclonal antibodies? Because, you know, and we talked about equity. It doesn't always work to say, well, we have a spot for you at 4 o'clock tomorrow afternoon, you know, in the infusion center. Well, maybe they can't get to the infusion center. So trying to think through that. Next slide. So we have, and this is still new in Sentara, and we're working through this, but we're building an ED pathway. So the patient, you know, if they're sick, they come to the ED. So for the much milder patients who are being seen in another center or their physician's office and getting a test, this may not work. But for those that are in the ED, if they're there, then if they have a test, great. If they don't have a test, well, then we have our next quandary. So most of our testing is PCR testing through Roche Labs. We have some rapid PCR testing, but not a lot, and that's through the Cepheid platform. So we don't have a lot of the rapid PCR tests for turnaround. Some of those we use for behavioral health patients. Some of those we use for moms that are delivering. So, you know, we're trying to figure out, do we have enough rapid PCR tests to then do this in the ED? And so we're looking at that, weighing what else we're using that test for. But let's say that you're in the ED and this is something that we should do, and we do this rapid PCR test. Well, great. Now we have a positive test. We're still early in the disease course. You know, 10 days is a long time. We're trying to get this when the viral load is higher. If that is someone who can get to an infusion center, it's a little bit easier to go to the infusion center. And so we will try to schedule that. But if it's someone that can't go to the infusion center, either because of transportation issues or other comorbids, we will try to do it right there in the emergency room. Next slide. Like everybody else, we built order sets to make it easier for the ED physician, so they can just click on the smart phrase and everything, and that's all built, which makes it a lot easier. Next slide. And then we've done this for several weeks. We've done about 30 infusions in the ED. You know, one of the problems is now you have an ED. Let's say your ED is overflowing with patients, as many of us know that experience. So if I have an ED and I've got people waiting in the lobby or people on a gurney in the hallway, you know, saying, I'm going to use that bed for another 2 to 3 hours, that's a problem. I know we're talking about time, you know, for infusion in a minute, but you know, that certainly is an issue that we are concerned with. Do we have enough nurses in the ED? You know, if there's not capacity for nurses to do this infusion to keep these patients, that is certainly an issue as well. We have to be able to have the hospital pharmacy to do the compounding that's there. And again, needing to make sure that the physicians and the providers understand the EUA, understand you know, who we can give this to, that we can't give this to someone who's sick that's 15 days out. And you know, they have to be higher risk, and so making sure that we have a clear understanding with our providers and also for our patients. And from the patient standpoint, looking at that, this is clearly very, very patient-centered. I am in the emergency department. I am sick. I just got my test. Oh, I can get a treatment for that right now. I don't have to wait for 2 days to go to an infusion center. That is very patient-centered. Again, balancing out the other issues that we talked about do we even have capacity in the ED to manage those patients? Next slide. And so I would love, Chris, for these numbers to be much more than they are. I will say that over the last 2 weeks, we've really started to kick it up. So we're doing a lot more monoclonal antibody infusions over the last couple of weeks. So it was a little slow to begin with, but I think that between this and what we're doing in the ED, that's going to be helpful. I will say, and I don't have a slide that speaks to this, that we've actually started to look at a very few skilled facilities. So we've worked with Sabre, and if a patient's in that nursing home and meets the criteria, if there's 2, it makes it easier. We will send a nurse and the medication to the skilled facility, do the infusion there. If it's 1 and it's less efficient, if the patient can travel, we'll do it in the infusion center. We're still new to that as well, but I think that's a third way that we can get medicine into patients. So again, we've been doing the clinic model. It's been working well. It's where we get most of our infusions. We are now looking at an emergency department model with the limitations we talked about, and we're still very early into going into skilled facilities. But that's sort of the Sentara experience to date. Next slide. All right, thank you.
We'll turn it over to you, Aaron and JP.
All right.
Thanks. I'll start. Yeah, I remember November, it was kind of like we were looking at the tsunami coming. I think we all just were in denial, including myself. And it was very quickly that we realized we needed to figure out ways to, control hospital volumes, control ED volumes, and get a handle on this. This is about the time this medicine became approved by EUA. So Aaron and I were kind of tasked with not only just figuring out how to distribute this monoclonal antibody, but also how to really optimize ambulatory care and really optimize the timing of inpatient care, keeping folks at home as long as they could. So we created our extended COVID-19 care clinics, mainly to give the infusion, but also as an alternative site of care for folks acutely ill with COVID. We bought, thousands of pulse ox meters, and the idea was like everyone coming in who's high risk gets a pulse ox, everyone in primary care gets a pulse ox. We optimized testing, getting as rapid testing as we could, and then a referral to our extended COVID-19 care clinics. Next slide. So yeah, I'll just kind of go through. So, we started on December 7th, really starting these infusions and starting our clinic. And as we were playing this, we were trying to figure out how, what the staffing model would look like, whether we would use our primary care staff, we have a transitional clinic. We were going to use our staff mostly to do telemedicine assessments to really, discuss the therapy with patients and decide, who should get it. What we finally settled on was a mix of things, but primarily now we were very fortunate to have our ER colleagues at staff, our satellite ERs who had sort of lower volumes because of COVID really step up to the plate, and they're managing this in entirety. So, overseeing infusions, they're doing telemedicine assessments, and they're also periodically doing in-person assessments for folks that are, sick, but not sick enough to need the ER or hospital, just to, quick eyeball them, give them some fluids, and send them home if necessary. You can go to the next slide. So yeah, most of our infusions have been in our satellite ERs, and we recently added our research site. We've been doing infusions at Inova under protocol for many months, so we were kind of well familiar with these infusions. So we've done about 1,000 infusions over the since December 7th. Again, mostly in our outpatient centers. And then slowly we decided that it was efficient to give them in the emergency rooms when volumes were okay. So we've actually been doing a fair amount in the emergency rooms at the time of discharge. So we'll go into kind of the details, but we made it relatively easy for Inova physicians to refer patients. And then we have a community referral for community physicians. We've advertised as, hey, this is how to get folks enrolled. We have a web-based referral order and also an Epic-based one. So the team really, the ER staff and the other staff will do telemedicine assessments. They're pretty quick. Most of them, when I've done, they've been by phone, and that's actually quite efficient. Even bypassing video, as a lot of folks have had difficulty doing that. And we'll deem them. We'll talk about the medication, make sure they meet criteria. We'll put the orders in, and then our scheduling folks will call them and make the appointment at one of these different sites. Next slide. And then we've been able to sort of track things. Again, we had our kind of peak, I think, delivery was sort of right after New Year's. It's actually been a steady decline since then, I think, which really just mirrors the burden of cases that have been going down over the past few weeks. In terms of equity, I think, we made a decision to advertise as best we could. I specifically reached out to our federally qualified health centers and our safety net clinics, basically giving them no barriers access to this care. I can't say we've gotten a lot of folks directly, but we have a pretty generous financial aid program at Inova, and the idea was really that folks would not have a financial burden to get this treatment. And I think we've done reasonably well in terms of ethnic and racial backgrounds. If you look at the slide, again, most of them Caucasian white, but the rest kind of mirrors, I think, the demographics of our community. So I feel like, this is reasonable. And also you can see sort of the region we've reached out to a fair amount of folks in the Northern Virginia, kind of Southern Maryland area, and I think even out to West Virginia. Next slide. And then we're able to sort of, keep track of our inventory in terms of, what we're using in terms of bamlanivimab and the Regeneron product. So as you can see, a lot of inpatient use of remdesivir, that sort of mirrors, and then the fall kind of mirrors our outpatient uses of monoclonal antibodies. Next slide. So yeah, we kind of went through a workflow in the beginning to try to figure out how to really operationalize this, and it was very complex. But again, I was just very proud of the whole Inova team, from the Epic folks and the ER docs, the scheduling folks. Everyone just stepped up to the plate and made this work. So I think we had we developed a pretty clean process for folks that works pretty well. Folks, now we're really optimized. We have plenty of infusion chairs, plenty of staff. And folks are pretty much able to get an infusion on the same day at the time of the referral. We've optimized testing. We've always allowed rapid testing or antigen testing to qualify folks. The one thing to speak about homebound and nursing home folks, we just decided that we would really just work with case management to transport those folks to the sites. It's very difficult to operationalize nursing staff. We have some infusion partners, our home infusion team that does work case by case with skilled nursing facilities, as long as they have the staff to do infusions in those facilities. So for the most part, we've been able to transport homebound and nursing home patients to our infusion centers without much issue. Next slide. Yeah, so this is just kind of one iteration of our referral order for physicians in Epic. They kind of click off all the criteria to sort of, keep them honest. And then once this is placed, we also ask them to say, when is the time onset of symptoms? And this will allow us to sort of, as you did, go back and study, hey, what is, how well are we doing? And hey, if we're doing this earlier on, are we getting a bigger bang for our buck? And I believe that's probably going to be the case. We're currently going through that data right now. Next slide. And then, yeah, this is our community form that, physicians can also fill out on behalf of their patients. And then we have kind of two-way. The patients can either call immediately to schedule, or our scheduling staff will call them immediately, get them scheduled. We've also decided, if you're over the age of 65, if the patient's very clearly like, yeah, I just want the infusion, and they're not, super sick, we're just fast tracking them right to an infusion and kind of foregoing any kind of telemedicine assessment, as it's very binary at that point after the age of 65. Next slide. Oh yeah, and we've also, this is another way of fast tracking. Just, hey, if you just want to schedule that patient, you're an ER doc, you're discharging that patient, you've had a discussion, put the scheduling order, someone will call them and get them in the infusion clinic. Next slide. Yeah, again, I think this just shows it was a big team effort, and really, I think again, one of the goals was to get ER physicians and primary care physicians comfortable with saying, look, go home, here's a pulse ox, here's how you use it. This is when you need to come back in the emergency room. And I personally, I've done that. I've discharged folks from the emergency room, say, look, here's your pulse ox, come back. And, they did come back, but hey, that saved us 2 days. And, there was no reason then to be in the hospital for that 48 hours. We optimized their use of the hospital, and I think there's no issues with safety when you're employing that with the right patient population. Next slide. And yes, I'll let Erin kind of pick it up from here.
All right, thanks, JP. It's really important to show that it's a team effort. So we wanted to show you the faces that really made this happen at the end of the day. So you see members of our Reston COVID clinic. And this is one of the offsite emergency rooms that we utilized. And just to point out in this photo, you'll see, as Dr. Bundy noted, you do need a different egress in terms of entrances and exits for these patients. So that what you're seeing behind you is that door that the patients come through, which is one of the doors that the patients come through, or in terms of how they move through. And then to the right, of the nurse with the PAPR on is actually where we have these patients located. So there's 4 bays. It's small. It's a small location, but it was important from an infection control perspective too that we had a door specifically, which we didn't have before. You can move to the next slide, and I'll show you. This is our Lorton team. So Lorton is a larger offsite ER. And I'll go through the timeline of events and how we made this really efficient, and we're able to expand capacity immediately by moving from the offsite ED downstairs, which they had a room that could fit about 5 bays, to upstairs to an ASC, basically a surgical area that we were not utilizing, that could hold up to 20 patients at one time. And this is huge. I will say we have not had the ability to do that. Technically, this, they could do up to 60 patients a day if the space was fully being utilized. We haven't found that to really be the need. So we're talking operationally about what we're going to do next in terms of how to make it more cost effective at the end of the day. But these again are the faces behind really the work that has made this happen. We keep moving. You will see this is Mike Kohlmeyer, who is our medical director for the Lorton emergency department, and also really took the lead and thought through from an innovative perspective as to how to make this most efficient. So this is in between telemedicine consults. So we do have at this point providers that are there to help with the clinic patients, and they're also doing telemedicine consults while they're at it. We can go to the next one. This is the Fairfax Clinic team, and this was really innovative. What we did was we took the research team, which for months they've been doing these monoclonal antibody infusions from a research perspective. So we said, why don't we do this? We'll keep the research going for patients that don't meet the criteria, but let's split that and utilize your same team to actually do this on EUA patients that do qualify. So they can do, and that's located on the Fairfax Medical Campus in a clinic that's kind of off, not in the main inpatient area where there's easy access in and out. And they can do 4 patients a day, which has also helped tremendously. So in total, it gave us the ability to have 3 clinics specifically for the community. And you go next, we'll talk about, I think, the media coverage. So we just had a little bit of media coverage occur through Channel 4. And this really highlighted, I think it helped us a little. What we decided when this happened earlier last week, it was that we would open to self-referrals. So anyone calling the phone number that NBC Channel 4 gave out, we would immediately, we wouldn't need, necessarily a provider order. We could go directly to telemedicine to see if they qualified. And we have done some of those successfully. And I think just for anybody thinking about that, I would say that's something you should definitely move forward with. You don't necessarily need a provider to refer. If we keep moving, I'll talk through this one for a while. So this is our timeline, and I think, let me go through some of these points as you might be thinking, as we were, a lot of these considerations. So first, scheduling, and I think Dr. Bundy, I saw on his slide, this was a big consideration as well. We really had to figure out who was going to schedule all these patients. Primary care really wasn't in the position at that point to take all of them on. So we utilized actually our radiology scheduling team to do this 7 days a week. And it did require them to increase their staffing somewhat, but I think they've been really efficient at doing it. The legal and regulatory review as to where these clinics could be located. The hospital without walls waiver will allow you to co-locate these locations within any of your inpatient or ambulatory spots. For us, it made most sense to initiate this in our 2 offsite EDs that I showed you before, because we weren't sure what these patients were going to need and what adverse reactions they would have to the medication, and also they're COVID positive high risk patients that are coming in. And we also had the consideration, as Dr. Bundy mentioned, that you can't really put this in your regular infusion clinics, because who is in those infusion clinics? They're typically immunosuppressed patients that you don't want to co-locate. So that will allow you to move in that direction. And the other thing that we've recently gone back and forth with is we initially had separate staff and separate providers within the ED, and the Joint Commission provision does not mandate that you have separated staff. So we are going through kind of changes at this point to make this more cost effective, to utilize our same emergency department staff at this point for this. We're going through what do we do when the patients need something in addition to just the infusion. But that's an important consideration if you're thinking of expanding this at your own location. One thing that makes it a little complicated from an Epic perspective, or whatever EMR you're using, I would tell you that think about, we had to go through a whole clinic Epic build, which is different from what our emergency providers utilize. They utilize the ASAP module. So they do have to toggle back and forth within that, and it does require training, which is not insurmountable, but it's something just to plan for. From a professional billing perspective and managed care contracting, I'll tell you, the payment for this is $309 from Medicare for the administration. As Chris noted, we are not billing for the actual medication, but it is something to consider, because that's not a lot of compensation at the end of the day for a visit that is anywhere from 2.5 to 3.5 hours. Plus you have the schedulers, you have a kind of fixed cost there. Plus you have to pay for the telemedicine in some capacity. And from a professional billing perspective, it's hard to know in terms of, we have our emergency department team billing for that on their perspective. We're not billing on that piece. We're just billing on the hospital end. So with that, definitely something to consider. One thing I will note that's important, as JP noted, we just started at about in mid-January. We went live with our emergency departments all being able to give this medication, which is very patient-centered and best for the patient to get that sooner within their COVID onset. You can do Medicare will allow a split bill. So in other words, you can bill for the ED stay in addition to the clinic COVID medication. You can bill for the $309 in addition to that. So they allow that just like they allow for vaccines. So that's something definitely to consider. Staffing ratios in terms of from a nursing perspective is something really, I think, to play with. Our nurses started out with about 1 to 2 patients at a time. They can go a little higher, but I think that's something, definitely it depends on how frequently you want vital signs to be checked, etc. And then the telemedicine consideration as well, and who's going to do the telemedicine, because you definitely need to we need to qualify these patients somehow, especially if they're coming from self-referrals or from the community. So you can see what we did in mid-December. The testing delays, we're fortunate, I will say, to have rapid testing throughout all of our emergency departments at this point, all of our urgent cares, and then rolling through our primary cares as well. That makes a huge difference in the delay time and when this can actually occur. When we started to see that occur in our EDs and urgent cares is really when we saw efficiencies come through. The other thing that we'll say we did most recently was, you can see in mid-January, we determined how to pull patients that were getting COVID tested out in the community through Inova. And we said, okay, if you are already on the diabetes register, or we can tell what your BMI is, or we know your age, we'll immediately pull you in to that Epic work queue to get scheduled for a telemedicine visit. And that also has, so we're trying to pull instead of just wait on community referrals as well. And then I think just in terms of, you can see everything I think we went through for the most part. I think another thing to consider is you don't have to have the patient sit in that infusion chair for 2 hours, because it used to be, just until recently, was 1 hour infusion and then 1 hour monitoring time. You can actually move them for the monitoring to a different location. I think which will help with efficiencies at the end of the day. And I think we can go to the next. And these were just things to consider. We did just today, we're trialing going from that 60-minute infusion to trialing to 30 minutes. We're doing that slowly to understand if we have any adverse reactions from that. Self-referrals, as I discussed, I think I would advocate for that. I think it's a good idea, and certainly helps our patients that are wondering if they are eligible. Where can we co-locate long-term? I believe that hopefully, as the monoclonal antibodies are more and more effective, we should have some mechanism long-term to make this happen. Certainly, we've found success in that working in the emergency departments. As Dr. Bundy mentioned, yes, there are times where you can't have a patient use a bed from 2 to 3 hours, but we've said is, why don't you call one of the offsite EDs that's affiliated and see if there's more space there, and the patient can then move over to that perspective and quickly get the infusion and just make it as efficient as possible. I mentioned the reimbursement. Like I said, we are going through right now. This is not a profitable endeavor at this point for Inova, and that's mainly because of the number of staff that we're utilizing, doubling that staffing within the emergency departments. So we are looking at what we can do to make this more effective, but of course focused on safety at the end of the day. I put the readmissions piece in there, and then also the home health and skilled nursing facility piece JP alluded to. We have partnered with Inova we have a joint venture with our home health company. So within that, we have said, if you have a patient that's eligible, we're working out how we can do that. We haven't had any real patients that would meet that criteria at this point, but as we do, we're trying to really be innovative with that. And I think that's it.
So, Abraham, if I could just make one comment here. I just want to say, wow, those were really great presentations. And, on behalf of VDH, I really just have to thank you all. You both, or all three rather, left out one key thing in your presentations, and it was you. It was your leadership at these centers that really, drives this operation and this success. So not only thanking your systems as great exemplars for all of us, I think, but you personally, because I've had conversations with people all around the state, and your group was picked for a reason, and I want to just thank you for that.
Excellent. Well, yeah, I would echo Chris's thank you to all of you that presented. We do have a few questions that we'll try to get through, because I know we have a hard stop at 1 o'clock or ideally 12:59. So the first question, should we be using these agents with hospitalized patients?
So I'll take that one. So the answer is no. If a patient is hospitalized, the EUA is actually very clear in the early phase 1 and phase 2 data, there were some attempts to use bamlanivimab in hospitalized patients, and there was a non-significant trend toward worse outcomes in those. So that's to be avoided.
Okay, next question. Any experience with sub-Q infusion versus IV?
All right, so that has also not been approved yet. However, just in the last 2 weeks, we've been seeing additional suggested applications for the monoclonals on prophylaxis. And so one of the studies at least has looked at lower volume subcutaneous injection of these agents for prophylaxis for close contacts and healthcare workers who are exposed.
Excellent. Next question. Does anyone have a standard form or a template for patient consent?
We do, as a part of that. That's within our order set, and we're happy to share that. I think that might be something that's standardized from the drug manufacturer.
We have that as well.
Yeah, we're happy to share.
We can make that available. Next question.
And we're also working on some toolkits at VDH, which we'll share with VHHA. A lot of this is things that have come from Operation Warp Speed to help people get started.
Next question. What is the benefit of using the newly approved dual medication therapy versus the single agent? Any downside?
I don't think we've done it yet, right?
Right. So the results are actually very similar. They had a multi-arm study with looking at bamlanivimab versus the combination, and the combination did a little better. And so I think we're going to see a shift if we can get our hands on supply towards the combination therapy. The Regeneron product was not compared head-to-head. The Regeneron product is 2, and I personally think we'll probably see some shifting towards that until we get both of the other agents.
One thing that I think is really important to note is that the Regeneron product, because of the way that medication is labeled, we found is safest to be mixed by the pharmacy team. And so what we've done is we only have Regeneron being given on our on-site ERs. For our off-site ERs, we have the bamlanivimab that is being given. That's very easy for a nurse to mix and give. So I think that's important for anybody considering how to do this.
Next question. Do we have statistics on adverse events to date?
I can tell you our personal experience, it's been almost 0. We might have had 1, but it's been negligible.
So in the studies and what's been coming out of observations in centers across the country is basically everybody says less than 1%, and the vast majority of those are mild reactions, things like hives, but not full-blown anaphylaxis. Probably anaphylaxis less than 1/10 of that.
I agree. I've been abreast of all issues. We've done 1,000 patients. I know 2 folks that the infusion had to stop because of a anaphylactic-like reaction, both self-limiting, and they were discharged without any incident. So it seems to be very safe.
Next question. For small rural hospitals, staffing infusion versus ED versus inpatient acute care can be a zero-sum game, particularly given COVID-related absences quarantine. Any wisdom or best practice to suggest for rural facilities?
I would say, like we've noted, depending on your ED volume, you can commingle staff, meaning that you can utilize, there's no provision against this, and looking into our legal team, the risk is small, if anything, to commingling, having staff that are giving this infusion in a clinic environment, in addition to doing something else. And again, the hospital without walls waiver will also allow you to do that from a location perspective. That's something we struggled with from a staff. The staff is limited everywhere, so I would highly encourage that. You don't want to have extra bodies for this. It's very easy to give. You just need nurses that can put in an IV.
So Abraham, if I could make two short plugs here. I really appreciate all of Aaron's insights in terms of the operationalization, and just loving to hear you say it's just plugging in an IV is pretty important. But we do also realize that every small hospital is not going to set up this program. And one of the things that we have been working on is with large systems in every region of the state to have essentially a referral network. And we will be rolling that out hopefully within the next couple of days as we get all of the referral information. So every smaller hospital or clinic throughout the state would have a partner who is able to infuse on a referral basis. So not from the VDH standpoint, we're not ready yet to say, okay, public self-referral, but really want to open that up to all the providers out there. The other quick plug I wanted to make was regarding testing. And I think Dr. Bundy and Dr. Vitorisi and Ms. Hudson also mentioned rapid testing. If you are at a center that needs rapid testing for the purpose of standing up a MAB program, VDH has a stock of the Abbott Binax Now cards that were given to us by the federal government. They're very easy to use. They've actually been approved for home use at this point, but we can get you those. So if you're thinking of standing up a program and your barrier is testing, please look on the information here and contact me or Abraham, and we can set you up.
Absolutely. Next question, given the significant impact of COVID in skilled nursing facilities, long-term care facilities, should more attention be put to servicing patients in these facilities?
So yeah, we didn't focus much on that in this presentation. We're working very closely with the VHCA organization and LeadingAge to really offer this therapy there. There's a parallel federal program that also supplies antibody to those facilities. It's all about the logistics. It's, you know, each facility has to determine, can they support the infusion or does it make more sense to refer? And we've seen both combinations throughout the state. But you're absolutely right. If we can treat in place or keep those folks from needing admission, that's a big win.
And I do see a comment, someone says, we have had success using this treatment in skilled nursing facility of Friendship Health in Roanoke under supervision of medical director and pharmacist, and you stated consent and order set would encourage others to consider this. We are usually able to initiate within 48, 72 hours of diagnosis. So there is some success in that regard in some parts of the state.
Yeah, the other outlet that I'll mention are dialysis centers, and we've seen several dialysis centers across the state, not to name drop, but DaVita being one of them, that they have figured out ways to also administer to their COVID positive patients. COVID positive dialysis patients still need dialysis, so they actually are in these clinics getting treated already. They've got IV access. It just makes sense if you can make it work.
I know that at least one of our presenters might have a hard stop at 1 o'clock, so if you need to jump off, I understand, but we've got several questions in the queue, and so I may just keep going until all of our panelists disappear, and then we'll stop.
I'm fine.
Okay. Any flexibility for using positive antigen instead of PCR to qualify?
Yes.
Yes.
Do that.
How are you handling the patients who have received one or both doses of COVID vaccine but still develop COVID infection?
So we've, generally gone with, just offering them the infusion, and then, they inform them that they should wait 90 days. I mean, I feel that, if you've been acutely infected and recover, and also have, monoclonal antibody protection, that's virtually like getting a second vaccine or first vaccine. So kind of reassuring folks, and it has not been an issue.
Did someone mention that the infusion time has been changed?
Yes, it has. It's gone from the manufacturers now allowing the drug to go from 1 hour decreased to 30 minutes. So the rate has gone up.
I think there's even quicker options too, but that's the one that we decided to try with, slowly, so we don't get into, adverse reactions.
Any data on using this prophylactically for the skilled nursing facility population?
So that's starting to come out now, and there are a couple of studies underway. I would not be surprised if we didn't see another EUA for that indication. That would be a very interesting occurrence if that happened, and I do think that subcutaneous administration would probably be the key to protecting a big group like that.
Chris, one you might be familiar with, we've been using BAM exclusively at UVA due to the ease of administration relative to the other option I won't pronounce. However, I'm concerned about the in vitro data showing that BAM, with or without etesimab, doesn't have activity against the South African variant B1351. So far as I know, that variant hasn't been described in Virginia, but our sequencing surveillance seems lacking. Should we be thinking about making the switch to Casdavam, Ibidabam now, or can we rely on sequencing surveillance to let us know if and when the South African variant starts being transmitted locally?
Okay, first of all, Abraham, I applaud your courage in trying to get through those pronunciations. But it's not a bad idea to get used to the combination therapies, because I do think that the monotherapy with the BAM is probably on its last couple of months, and hopefully we'll get the supply of those. So I would recommend, sort of working through process to be able to deliver combination therapy. In terms of the variants, there's a lot of moving parts with what we're looking at VDH, and I know what the CDC is starting to recommend around the variants, and I think we're going to have to wait and see. I'm not sure if Aaron or JP, if you have other thoughts on that.
JP, I'll let you speak to that.
Yeah, no, agree. I think we just have to be nimble, be ready to make these changes. I think the data does show that the combination is looking better. And yeah, I think it's, time will tell.
Yeah. Somebody did ask about the hospitalization rates. And again, what we're seeing are case series come out in non-controlled settings, but large administrations, from different states, large systems. So the typical thing you'll hear now is System X gave 3,000 doses and the admission rate on their patients were less than 1%, which, when you compare to the historical data, is usually about that 70, even 80% reduction. So I think it's holding true in practice. The unfortunate part of this rapid evolution of this whole pandemic response is people don't feel that it's appropriate to conduct long randomized controlled placebo controlled trials. So we're not going to have that level of evidence anytime soon. But at least the observations have been very positive on both the safety side of things and also what the experience of these patients have been.
You still monitor post-infusion for 1 hour?
Yes.
Yes, we do.
That is still required.
Okay. Well, that was actually our last question, and so I'm going to actually put in a little personal comment here before we end, and it kind of goes to Aaron's comment about the pull methodology and the self-referral. Last week, right before I sent out this webinar announcement, I had my sort of 6-month touch base with a colleague, dear friend who retired several years ago. Her mother is 94 years old, lives in outside of Lynchburg, and I'm always a little bit leery about the status of her mother. And so halfway through the conversation, she said, "Oh, and my mother, who's now 94, got COVID." And I was like, "Oh, no." And she said, "But my doc called this doc at UVA and said, your mother needs to get into the COVID clinic." So got her into the COVID clinic the next day. She took a little snack with her, got this infusion, spent 4 hours, and she is doing just fine. You all need to do more to let people know about this monoclonal antibodies. They are wonderful. I said, funny you should mention that. But she said, you need to get it out to where people are being tested and to the docs in the community, because more testing is occurring outside of the hospital setting. So how can you get this option somehow attached to those positive test results? And so she really was talking about this sort of, pull and getting people to be aware of it and self-referring in, as opposed to the hospital having to do all the reach out.
I agree completely.
Yeah, I was really impressed, Aaron, when you mentioned the pull related to identifying patients through your system, through your EMR, and reaching out to them. I think that's a best practice that I've learned today that we'll make sure to share with others. And Abraham, to your point, this is again why we're setting up this regional network. So we're going to be communicating more actively with primary care physicians and emergency physician groups across the state. It's a novel idea to think about, putting information about antibodies on the actual test results. Who knows? Who knows? Maybe we can talk to LabCorp.
Well, again, thank you all very much for your time this morning. I think it was very well received, and I will be glad to facilitate any additional follow-up. And please know that your Virginia Hospitals and Healthcare Association is here to support you in any way that we can. Everyone have a great afternoon.
Thank you.
Thanks,
Bye.
everybody.
Bye-bye.